Thank you. I'm going to do my
so
presentation,
Yeah, okay.
and then I'll introduce you to the live case that we're doing, and then we can continue. Okay, go ahead. So basically what I'm going to talk about is radiation protection and the exposure to the dangers of radiation, especially in complex thoracoabdominal aneurysms like you mentioned. I know the technology is getting better. I know the devices are getting better, and our skills are getting better. But still, on an average, even if you're doing 2 renal fen cases, I think the exposure to radiation is still a major concern. The lead apron that we use is less than Epiocure, and I don't think it protects us or everybody else in the room adequately enough. Next. Go to the next slide. So, in addition to that, because of the issues with the heaviness of the lead and constantly putting your head down, physicians and basically interventionalists are exposed to back pain, neck pain, and you've heard of instances where doctors have had cervical spondylosis, cervical neck compressions, decompressions, and also the fact that they've exposed to radiation and have suffered from cancers. Go to the next one. And a classic example, of course, is my mentor, who I worked for with 20 years. And if you look at the exposure data that is causing so much of concern is that an estimated 50 millisieverts to 200 sieverts of ionizing radiation over the course of a career. And it equates to almost 2,500 to 10,000 chest x-rays. And obviously the brain has the greatest exposure. And so we've had leadless aprons, we've had brain leaded hats and things like that. But the overall protection, not only to the operating physician, but also to everybody else in the room, is not totally adequate. Next slide. So there are novel radiation protection barrier systems, one of which is called EGG Medical. The second is Radiaction. The third, of course, is zero gravity, which is still like not even basically a system, but basically a lead gown, Rampart. And the fourth system is something called Protego systems. So basically, if you look at radiation protection systems right now, we have 4: EGG, Radiaction, Rampart, and Protego. So our experience with these radiation protection systems started with Protego actually. And it's basically involved a lot of shields like this. And a lot of this radiation protection system was actually used by the interventional cardiologists for PCIs, and Dr. Isaac was a proponent of this radiation protection shielding system. It's cumbersome, and we felt that this was not totally adequate a system, not only in terms of exposure, convenience, removing it in case you had a rupture of the abdominal aorta, and we felt that this was not the ideal system for thoracoabdominal aneurysms, complex thoracic aneurysms. But for coronaries, I think it protects the operator well, but I don't think it protects the anesthesiologist or even the person who's doing the transesophageal echoes during TAVR procedures. Next one. And this was the original data that was actually introduced and presented by Dr. Isaac and has been published in Sky. Go to the next one. Next slide. And so you can see that there's a marked reduction in radiation, especially if you look at the waist, the Protego system and the thyroid systems and the controls. And you can see there's marked reduction to the operator itself compared to standard procedures. Go to the next one. And this was actually published, 2 publications in the journal at Sky on coronary and structural heart interventions. Go to the next one. But our cases are totally different, and you and Ben and Sanchez know that these are even for the TAMBI procedure. In fact, if I heard right, one of the TAMBI procedures, there was almost huge amount of radiation exposure that is actually may even become sentinel events and concerns for the patient too. So these cases, not only the planning, but the execution and the time and the amount of radiation and contrast used definitely have to be considered when we're doing these complex cases. Go to the next one. So right now in the United States, we basically have FDA-approved devices, which is the Cook Zenith Custom Fenestrated Graft, and of course the TAMBI graft, which Dr. Sanchez spoke about. And we're very fortunate to have been able to do these TAMBI cases also here at the Honor Health Network. Go to the next one. So we started to use the EGG radiation protection system. We do have a Philips system here. In fact, the case I'm doing right now is from the cath lab because we're rebuilding a hybrid OR at Osborne Hospital. We do have another hybrid OR at Shea and one at Deer Valley too. And all of these I think, are going to install the egg radiation protection systems. We do a fair amount of complex abdominal aortic aneurysms and thoracoabdominal and thoracic aneurysms too. I think Honor Health was the first hospital system to actually enroll patients into this egg radiation protection systems, the first in the Phoenix area. Go to the next slide. So we, having installed the egg, as well as using, go back a little more. After that? Okay, fine, that's good. Go to the next slide. We also installed FORS, fiber optic real shape. Now, this is our image-guided therapies. Next one. Go to the case report, yeah. So this is image-guided therapy that is light-guided and basically does not use any radiation. And you can do this without any fluoroscopic imaging too. So let's take a look at this case. 81-year-old female who came in with a large pararenal abdominal aneurysm, severe comorbidities, EF42, prohibitive risk for open surgery. Go to the next slide. And here you can see this case. If you can play that video, let it play if you can. You may have to click on it. Yeah, so there you go. And you can see this is a large aneurysm, and you can see the two renals are actually coming back almost from the aneurysm itself. Go to the next one. Next one. There you can see. Go to the next one. There you go. Next one. And you can hardly see the takeoff of the renal artery. So this is a very, very complex, even to get into those renals, especially in a patient who is a prohibitive risk for open surgery. Go to the next one. And there you can see the right renal coming off the aneurysm. The left is a lot posterior, lateral. Challenging case for sure. Go to the next one. So obviously a high-risk patient. We even talked to her about leaving it well alone. She's really not a candidate for FDA-approved devices. And so, Ben spoke about and even Dr. Sultan, in fact, I heard him say, we are criminally using physician-modified stent grafts. And so, yes, we are doing a lot of physician-modified stent grafts. A lot of us do not really have PSIDEs, but we are really modifying these stent grafts to fit the anatomy and morphology of these complex aneurysms. So the plan was to use a PMAG, use FORS, and use egg medical radiation protection. Go to the next one. And so we made our graft. Go to the next one. We deployed it. Go to the next one. And you can see that. Go to the next one. And you can see the fenestrations. Go to the next one. Lining it up at the SMA. And the details of this, I think Ben will talk a lot more at our lunch symposium tomorrow. Go to the next one. And this is what we call Phillips image-guided therapy. So if you can see the catheter and the sheath. So I use what's known as a destination steerable sheath. Through that, we put in a catheter that is registered to be to show on the screen fiber optically, and then the wire also. So the catheter is purple, the wire is yellow, and you can change your colors depending on what you choose to do. Go to the next one. And so you cannulate these along with the image-guided therapy and as well as a background of the imaging. We used to use SIDAR a lot, which is also good for preoperative planning. And then we cannulated these right renal with the FORS system, and then go to the next one. And similarly, the left renal, and of course, dilated the fenestrations. Go to the next one. Next one. And then finally, we got a really good result. And this patient is almost, 9 months out now? Go next one. Or even more, maybe. So with the combination of FORS, with the combination of radiation protection systems, and with improved technology and improved skills, I think these cases are being taken on more and more often. And physician-modified stent grafts are becoming more and more used. And I think there is a need to sort of standardize this, work with companies to see how we can get the best results rather than every physician doing whatsoever he chooses to do. But I think we need to standardize the procedures as much as we can and help physicians from a company point of view too. Go to the next one. And so with these combinations, you will see that we have reduced our radiation. The green is with the use of the radiation protection systems, otherwise with standard, and you can see with egg as well as FORS, the time, dye, and the number of radiation. Go to the next one. Yeah, as you can see here. So here you can see my radiation was almost zero with the help. So even the case we did in the morning, we had a 97% protection from radiation compared to the overall dosage, and it is equivalent to the patient and to the anesthesiologist and to all people in the room also. So there is, go to the next one. So there is an absolute need, and I think it's mandated that we use these radiation protection systems, especially in these complex abdominal cases and thoracoabdominal cases and fenestrated grafts and physician-modified grafts. Go to the next one. And I think VAS, and I think we should congratulate them, they really jumped on this. And there are multiple documentaries that Chris Woolley and Wayne Dickman have all put together called Scattered Denial. And I think there's a tremendous push for protection, not only of the staff, but also of the physicians and the patient from radiation, from the hazardous effects of radiation, especially in these complex abdominal cases. Go to the next one. Okay, so having said that, I'm going to just present the live case that we're doing. I have Stephanie Wilson, who is our nurse practitioner, and she'll go through the details of the case. And then while I'm working, we can go back to some of the lectures and may hopefully stay.